Is the managed care community as excited about this as I am right now? I mean, is the thought process for funding all of these treatments the same as for other cancer treatments, or is it different?
So let me start by saying that I'm an oncologist, right? And I don't have a lot of company in Aetna, and I would not have a lot of company in other insurance companies. And so oncology is an important thing because, well, for a lot of reasons, it is expensive. But it's also, there's also other stuff about cancer, right? So let's be honest, it's something that we pay attention to. And that Aetna, like everybody else, has been paying attention to for a long, long time. Are they excited? Yes. It's very exciting to see the advances. You know, I'm a little bit of a skeptic. I mean, I'm not an immunotherapist, so I'm waiting to see the results. I mean, I still remember when the IL-2 paper was published and we were going to cure renal cell cancer with IL-2. So I'm waiting to see what the results are. Do we distinguish? No, I don't think so. We don't distinguish immunotherapy from other targeted therapies. We're interested in, you know, what's going to mean to our members? Are our members going to get better?
Is this, what he just said, is this frustrating to you? I'm a skeptic. I remember IL-2. Come on, show me more.
I think it's healthy. No, I mean, we still give IL-2, you know, in limited circumstances, but we're frustrated by the limitations of the therapy. What we're excited about are the advances, which seem to be moving, you know, us faster beyond those limitations. And as Jeff said, this is, you know, the opportunity to move these therapies that are doing some remarkable things, granted in maybe not everybody, but in a subset of patients with advanced metastatic disease, to earlier settings. But do we have to meet a bar? Do we have to, you know, pass the standards that our skeptics set, that our regulatory agencies set? Absolutely. And, you know, we owe that, you know, to all the future patients out there, that those bars are met. So I'm not frustrated by it. What we get frustrated by is when we have met those bars and when people are still skeptical, because this doesn't fit the paradigm of traditional chemotherapy and shrink, you know, the cancer, you know, 20%, and therefore I know it's working in that.
I mean, isn't that the truth? When you give standard chemo, if you will, there are some things you can be sure of. Your patients aren't going to feel all that well. The tumor burden is going to shrink right away, and you're going to get all these...
If it works.
If it works. All these epiphenomenon. Whereas the immunotherapy is more subtle. Usually it's pretty well tolerated.
Although, hang on.
Or am I wrong about that?
Depends on what you're talking about. You'll hear again tomorrow that you can see tumor responses with PD-1 or PD-1 plus ipilimumab that are almost as impressive as you would see with chemotherapy or targeted drugs. You can see responses that happen rapidly, they occur steeply. So we're in a different realm, and as we expand the repertoire of drugs available to us, you're going to find that we will be able to overcome the skepticism, and frankly, immunotherapy has had a bad name for a long time, ever since the days of William Coley and Coley's toxin. This is the 1890s or 1880s. So there is some bad name and bad rep to overcome, which is why Mike said, I'm a skeptic. That's the classic attitude of most oncologists. I was once in a study section reviewing clinical grants, and there was a bone marrow guy who got up and said, when reviewing an immunotherapy grant, he said, you know, I really don't think this immunotherapy stuff works. And just, I mean, my piloerection, my hair's got,
I didn't say that, though. I didn't say that.
Well, no, wait, but you said you had a healthy skepticism, and I want to go back to something else. I mean, when you give traditional chemotherapies, it's all very nice that the tumor shrinks, right?
But that's a surrogate.
But I mean, traditional chemotherapies, the burden shrinks, the mass gets smaller, but there's a lot of side effects, a lot of fallout here. And if I heard you correctly, immunotherapy's safety profile is much better.
It can be, yes. And remember, let me get back to one thing that Jeff brought up. What is it that patients are after if he had cancer? He wants to live as long as possible. He wants the quality of life. He didn't say, I want my tumor burden to be reduced by 20%. You know, he didn't say that I want to
isn't that an
slow the
unspoken
progression.
assumption?
Those are, no, not at all.
Okay.
Not at all. So we have patients that have tumor burden that have a fantastic quality of life, and they're going along just fine. And you know, as long as that quality of life is going along and we're not seeing any detriment in terms of either the disease progression or their cumulative toxicities, you know, we're achieving their goals. So to me, you know, tumor regression is probably the least valuable of all the surrogates that we tend to use in our practice, because to me that's not as much what the patients are going to experience as the side effect profile that you refer to, the delay in disease progression, and ultimately the improved overall survival.
Now, I've got to tell you, I've been in this business a very long time. This is the first time I've actually heard an oncologist, maybe I haven't been listening closely enough. The first time I've actually heard an oncologist tell me, reducing tumor burden, not really what I'm after.
Well, let me qualify this that I'm a prostate cancer doctor. So for the longest time, we've had bone scans, which they don't meet RECIST criteria. They don't really even represent the cancer. They represent a reaction around the cancer, the calcium deposition around the cancer. And we've had PSA as a biomarker. We really haven't had measures of tumor burden. And it's actually been the biggest hindrance to drug development in prostate cancer over the last 30 years. And we've just finally gotten over that in the last 10 years. So to me, you know, I'm probably a little bit of a different oncologist than maybe what you've heard before.
But what you said just struck me as making such perfect common sense. Who cares what the tumor burden is if you're living longer and feeling well? Isn't that
Although,
what you
to be
want?
honest, reduction of tumor burden is usually not regarded as an end in and of itself. It is a surrogate or a substitute for the greater variable, which is obviously
enough.
survival. Progression-free survival, the same thing. Okay. On the other hand, there are plenty of patients who have significant decrease in morbidity and improvement in their symptoms and increased quality of life when they get some tumor reduction. So it can be a desirable endpoint, and the FDA does recognize in single-arm studies that tumor response, tumor reduction is an acceptable endpoint. They much prefer the ultimate endpoint, as they'll always tell you when you meet them, of survival in a well-controlled, well-conducted randomized trial. But, so I agree with Dan in principle, response is not the ultimate endpoint, but it can be a useful endpoint.
So take me inside